Hello. So where are we? I'm on this one. So a very wise man once said that we should stop, collaborate and listen. And I'm very glad to be here today amongst my peers doing exactly that. My name is Simon Wellesley-Miller. I'm a senior analytical manager in the Southwest Insights Intelligence team and also working in the Elective Recoveries Insights cell. So I'm trying to move this thing on. So let's start with a few basic definitions. Health inequalities. I'm pretty sure everybody's sort of heard about those, and that's the WHO definition up there. Obviously, many studies showing that it's a major factor in both morbidity and mortality rates. Waiting list. Unfortunately, you, I, and about 7.5 million other people know what those are. But what we've got to be really, really clear about is we're not talking about one waiting list. We're talking about lots of individual waiting lists by different treatment functions across loads of different providers. So what might be a cause of the wait or what's happening in trauma in Birmingham is going to be completely different to what's happening in dermatology in Cornwall. So the big question, what is health inequality? So say we had 95% female on a waiting list and 5% male. Is that health inequality or is that just the gynecology waiting list? So just trying to look at those descriptive stats on their own aren't very, very helpful. So as with gender, ever different demographics across different sort of treatment functions are going to sort of play a factor. So you're going to have certain age groups who are going to be more prevalent in certain lists than others. IMD itself has an element of health to it, so there's a real danger of sort of correlating you've got sick people on the waiting list, which is kind of where we would expect them to be. And the other thing is, 26% is a really good descriptive statistic, but if you've got no idea what you're comparing about, that to 26% on its own is absolutely useless. So last year for I did a master's degree in healthcare data science, and I did a project on looking into health inequality. So I came up with a hypothesis that utilised a test around the distributions of weights across waiting lists by different demographic features. So basically highlighting where there were statistical differences in distributions by features. So for example, in this example, we're looking at sort of age groups, and you can see there's a real shift within the sort of demographics of the age within this specific waiting group. Didn't necessarily mean there was a health inequality. That might be clinical need, but all it was showing is there was a statistical difference within the demographics of this waiting list, and then that could be taken forward to sort of ask further questions. Managed to get that into reproducible analytical pipeline and got all that sorted, which was great. And that was the end of my master's project and enough to get me a certificate and a silly hat, which is awesome. But analyst work is never done, and I was really, really fortunate to be working in NHS England and manage to sort of continue this work with a sort of national team, be put in a sort of a wider team and expand that sort of analysis further. So what have we been doing and how have we been expanding that question? So we really wanted to do some sort of comparison and compare groups of significance around what's happening with the long waiters and how does that compare to the shorter waiters. And could we then distill that down is to see if there was any sort of interpretable insight around what the difference is between the long and the short waiters are. And the very high-level infographic there accurately portrays our scoping and working through a clear analytical question to get to an answer. But that is kind of what we've managed to do-ish, or in the working. So if I just sort of go through our workflow, I'm going to let you into a tiny little secret here. And so some of the NHS data is not of the best quality. So I know it's shocking. And we found that the longer the patient was on the waiting list, the better the demographic data came in. So potentially, if you've been waiting on the waiting list for a year, there's a chance somebody might have asked you when you were born. So it becomes, again, really difficult to sort of do that comparison between those who were waiting a short time compared to those who were waiting a long time. So we've managed to join up to the sort of master patient index using some fabulous sort of Databricks and big data-y stuff to sort of link and get a consistent set of demographics across the whole waiting list. And managed to get things like ethnicity down from our sort of missing down to about from about 14% of cases down to about 6%. Not perfect, but really, really good in the grand scheme of things, and consistent, which is really, really important. Wrangling, so we did a lot of sort of basic wrangling, then sort of building it into sort of treatment function codes and grouping into ICB data sets, etc. And then with our master patient index, we could then also sort of convert into population rates. So again, if we're comparing ICB versus ICB, you know, there's no point saying, oh, look, the really small ICB's got half as many as the really big ICB, or the really small treatment function's got little ones compared to the big treatment function. So we could start sort of working out sort of population rates and sort of standardizing numbers. So we could really do that comparison and work out what were actual outliers rather than just, you know, comparing big v small. And then we started doing some sort of statistical comparison between our long waiters. So for instance, we've got a cohort 1 of short and long waits. And if we're looking at our blue patients, as you can see, we've got 10 of 100 and 1 of 100. And both of those 10%. So we can say, look at those two groups. We can say they're statistically similar. Yay. And then we look at cohort 2, and we've just changed it by 1. So we've now got 11 of 100 and 2 of 10. And that changes those percentages from to 11% and 20%. So there's that real danger of people looking at those two different cohorts and go, oh, look, the cohort's changed by 10%. That's, you know, significant when it actually isn't. So we use a combination of chi-squares and Fisher tests to do some sort of actual robust statistical analysis so we can actually work out whether those two groups were actually significantly different. And then we started to do looking into sort of clustering. So rather than looking at individual sort of specific demographics, look at sort of patient as a whole. So what you can do is run something called a Hopkins test, which allows you to work out whether your sort of distributions of your features are sort of just uniform, in which case, great from a health inequalities perspective, because that means, like, you know, everything's sort of spread out equally, or whether you have got sort of groups of patients, in which case we can cluster. Unfortunately, that's not the Hopkins test. That is instead, which is obviously not as exciting. Then we started, like I say, putting our clusters together. And like I said, rather than looking at individual features, we can actually start pulling together features and say, you know, is it elderly male within a certain ethnic group, or is IMD a feature? And what's really, really quite interesting about the clustering is it doesn't necessarily pull in all the features, it just pulls out those which are most important. And that changes from ICB to ICB and from treatment function to treatment function. So yeah, it's been really, really interesting on how that sort of works. And in practical terms, it might, you know, identify that there's elderly white deprived people in one major group, but gender wasn't an issue. So it starts sort of, instead of just looking at individual features, it sort of pulls those together. And like I say, that starts then sort of putting who are our sort of big groups within those waiting lists, and sort of working out who they are and what are the common features with those. And that sort of helps us understand then who are the sort of the secondary and sort of subgroups within there. And also, as I said, it rejects those sort of non-significant features, which is really, really important. So we kind of developed that into a reporting tool to explore this analysis. At the moment, we can investigate at regional, national or ICB level and across individual treatment functions. So we can look at orthopedics and Somerset and see if there's a change in demographics within those long waiters. The report's currently in our quarto, but we're looking to move into sort of our shiny soon, once we've got the appropriate security and access sorted out. And at this stage, we've got those sort of statistical comparisons in there, and we're looking at sort of adding in that additional analysis around things such as the rates and the clustering, and trying to work out how we can do all the sort of clever stuff in the background, and then sort of bring just the really, really easy to understand insights just to sort of the front page, as it were. So it's really sort of Schrodinger's, you know, analysis. We want to make it as complicated as possible, but as simple as possible to understand. So, as I said, it's still very much a work in process, but we are addressing some quite important and it's really, really interesting questions around patient care. Still working through those sort of populations, make sure those rates so we can sort of make sense of those and sort of get meaning from those. And also how we can sort of explain what is an outlier and sort of do that sort of statistical counterfactual work. The clustering, we're sort of trying different methods and seeing which is coming through with better results. Unfortunately, most of the data around demographics is categorical, which does kind of limit you in certain methods that you can and can't use. But conversely, they're quite interpretable methods, so they're not, sometimes if you're looking at sort of a K-mode system, it's almost embarrassing to call it machine learning because it's, you can do it on paper. You could potentially do it in Excel, it's that easy. So that's quite interesting. But, having that interpretability is also really quite important for sort of quality assurance and sort of confidence in what we're doing. And we're sort of very much interested in getting our methods out there into sort of a workflow and sort of available on GitHub. And also so we can sort of pull individual bits out of our workflow and apply them to the other areas. So for instance, if you've got a KPI and your KPI is failing, I think I've been in that meeting so many times where you've just said, right, we're failing this KPI. North team, why are you failing? Or South team, why are you failing? And it's very much about that kind of thing. So which team or which hospital, etc. What would be really cool is if we can actually cluster those patients who are failing and actually work out which patients are we failing and what groups of patients and what are the features of the patients who are not meeting this KPI. And that potentially then we could do something about it much more than just saying North team do better. So yeah, we're really, really interested in sort of trying to get some of that stuff out and just making some tools and some sort of interpretable stuff. So that's working. So yeah, really, really want to be able to make this much more sort of patient-centric analysis. Would like, again, just to thank those who support me in my master's and my sort of local and national team, and who've obviously given me the opportunity to continue this work. And that's me done. If there are any questions, thank you.